So here we're going to finish up the notes that we began in class regarding pregnancy and birth. And so where we pick up here are the events that lead up to labor once you've reached the end of a full gestation period. And sometimes, of course, you have preterm labor where this all begins to occur a little earlier than the 39 weeks we discussed. But essentially what it has a lot to do with is two components. So you're looking at hormones, but then you're also looking at some mechanical stimulation. So as far as the hormones go, typically at this point in time you have very high levels of estrogen and progesterone, and it's this increase in estrogen that builds up a large number of oxytocin receptors on the uterus. Now, of course, this is important because oxytocin is what's going to eventually cause labor contractions to expel the baby in the placenta as far as birth is concerned. So you have to have adequate number of receptors on the uterus for oxytocin to have that kind of an effect. So, of course, the other thing you see here are an increase in gap junctions between the cells of the uterus and the myometrium. And that's important because it allows the uterus to work as a single unit. When the cells can all communicate electrically with one another, then they can create pretty in-sync contractions so that it's an effective kind of labor contraction. So, of course, towards the end of labor or towards the end of pregnancy, sometimes you'll have false labor contractions, otherwise known as Braxton Hicks contractions. And so these are not considered able to intensify to the point that they would cause dilation of the cervix. So they're not true labor, so they should not actually cause birth of a baby, but they are contractions, and the uterus will typically tense up and hold. But if you can change position or if you can drink some water and they go away, then it's not true labor. It's just Braxton Hicks, as they would call it. So these things lead up to labor, and the fetus actually plays a role in stimulating labor. There are fetal hormones that are going to be produced, some of which from the fetal pituitary gland. Cortisol and oxytocin can come from the developing fetus itself. And so, of course, this is going to start to cause some of these oxytocin receptors on the uterus to respond and give you the earliest true contractions that exist. But that's going to be coupled to these mechanical events of the actual stretching of the uterus and then, of course, the pressure of the baby on the cervix. As long as the baby's in the right position, as we saw right here in this slide, that the head should be down, pushing on the cervix. And so that stretching of the uterus and the compression on the cervix, those will start to increase the likelihood of labor initiating. So with the true initiation of labor, or true labor itself, of course, as we said, it's going to be the series of events that actually expel the infant from the uterus, unlike Braxton Hicks contraction. Giving birth is also termed as parturition. Okay, so make sure you know that term right over there. With true labor contractions, they occur at regular intervals, starting pretty spaced out, and then begin to occur more and more frequently. And this should result in dilation, which Braxton Hicks will not do. And this is often marked by the loss of what's called the mucus plug. Also sometimes referred to as the bloody show. With the cervix itself, we talked at length about cervical mucus. And so here at the base of the cervix, here you can see the urinary bladder, but the cervix would sit right below all of this. You'll end up with that cervical mucus thickening and causing formation of a plug right there in the uterus or in the cervix. And so as the cervix begins to open up and dilate, that just automatically falls out. So that's one of the things that some women will look for as they are starting true labor. On the maternal end of things, her pituitary will start to produce higher levels of oxytocin. And of course, now that the uterus is prepped with oxytocin receptors, it's going to stimulate uterine contractions. This is also going to cause prostaglandin release from the placenta, and this is going to increase the contractions of smooth muscle of the uterus. And these are the maternal aspect causing labor to actually begin. So, of course, this is actually a positive feedback mechanism. As you increase contraction and stretching of the uterus, that causes more oxytocin to be released. So oxytocin levels will build and build and build, and as a result, contractions will build and build and build. And this continues to intensify until birth is actually completed. And so you can see that illustrated right here. So initially, high levels of estrogen, inducing oxytocin receptor development here on the uterus. So when oxytocin is going to be released, right, initially from the fetal pituitary, but then of course also from the mother's pituitary, stimulates uterine contractions. right? Causes the release of prostaglandins. And then, of course, that increases contraction strength of the uterus, and positive feedback increases the amount of oxytocin that's made. So positive feedback here. Make sure you know the role of all the hormones listed and how those tie into labor. So as labor is taking place, you divide it into 3 true stages. So dilation, of course, again, something you won't see with Braxton Hicks, at least not very much. This is going to be cervical dilation is what we're looking at here. So the cervix is supposed to dilate to 10 centimeters, and we give some hours here that are pretty average. So it on average takes about 6 to 12 hours for this to take place with contractions happening the whole time. Again, the contractions themselves are pretty widely spaced apart, so 15 to 30 minutes, initially lasting a very short while between 10 to 30 seconds. But as you get into the later stages of labor, and as the cervix is dilating more and more, those become more frequent, so every 2 to 3 minutes, and each contraction lasts about a minute itself. So in addition to dilating, the cervix itself will efface. We call that thinning. So it just basically reduces the amount of tissue there that has to be dilated itself. And that's, of course, going to be a pretty unique mechanism that looks a little bit like the way our ciliary muscles worked in the eye, where the muscles roll backwards. Of course, at this point in time, you could break the amniotic sac and the fluid can be released. And as the baby begins to drop down through this effaced and dilated cervix, we refer to that as engagement. And this is where the baby's head is actually going to start to enter what we call the true pelvis. So at this point in time, if the baby's head is above the cervix here, and if it's in what we call the false pelvis, so the upper region of the pelvis, they tend to be looking side to side, so towards one hip or towards the other. And this is, of course, if we say the baby is in a position called vertex. We'll see if there's actually a position or a condition in which the baby could be breech, and that term is right here, right? Where the baby is head up or butt down, we could say. And so the baby, as they're right here in the false pelvis, will then begin to descend and drop into the true pelvis. And as they do that, the head is going to start to turn. Okay? And so the idea right over here is as the baby's head is beginning to pass through the vulva, we refer to this as crowning. And so here you can actually start to see that happen, right? So crowning initially right through here, to the top of the baby's head, and then of course continuing all through this region. And of course this stretches the vulva quite a bit, and so something known as an episiotomy is often done, where they'll actually cut part of the perineum to actually prevent spontaneous tearing, which can be dangerous enough to actually tear all the way down towards the rectum. And this is very difficult to recover from, and puts a mom who's recovering from all the normal postnatal elements at a risk for infection and a lot of pain. And typically it's difficult to deal with that in the position that these new moms are already in. So of course that's actually referred to as expulsion. Right there. So this is when you think of pushing taking place during labor, and this can last about an hour or so for the first child, and then less on average for subsequent births after that. So of course then after you've delivered the baby, you have to deliver the placenta. So we think of it as placental labor. And this is within 30 minutes. Sometimes it's a lot sooner than 30 minutes to completion. But you could see there the placenta itself, right, outside of the body. You can see in these stages where the baby is being delivered, right, nose down right there through expulsion, the placenta stays intact, and then the placenta falls away from the uterine wall, and it and the majority of the umbilical cord are delivered at that point in time. So following labor, there's a number of things that happen. We refer to this as puerperium right over here, and this is the first 6 weeks of postpartum. And this involves the discharge of other elements of the endometrium, and this is typically referred to as lochia, but it's basically like a very heavy period that can last all the way up to about 6 weeks. And it's usually alarming for moms because it's larger pieces of tissue than what they would see in a typical menstrual cycle. Now, a couple of other terms that you would see at this point in time. Dystocia itself would be an obstructed labor for one reason or another. So, for example, if a baby is not in the vertex position, if they are breech or in any other abnormal position, then typically they will not continue with true labor. This is also true whenever women have either underdeveloped or smaller than normal birth canals, right, so the vaginal canal, or if for whatever reason, cervical dilation is not working appropriately and the baby is at risk, these kinds of things will cause the physician to move to a C-section. Okay, so of course with the C-section itself, this is done primarily for the health of the baby, but can save the life of the mom, depending on what the situation is. Once the baby's born, they assess the baby's health. They refer to this as generating an APGAR score on a scale of 1 to 10. And they look at things like coloring, reflex activity, heart rate, respiratory rate. And from there, they can begin to decide whether or not the baby needs to be moved to the ICU or the fetal ICU, essentially, or if the baby can be given to the mom. And of course, they continue to assess the baby right off, or assess the baby as time goes by throughout that day and the next day. And usually it's in with about 48 hours that a woman is going to be discharged with her baby from the hospital. But this APGAR score is what they use right off the bat to determine if the mom stays with the baby or if the baby needs to be taken to the PICU. So of course, fetal adjustments, you see respiratory adjustments, cardiovascular adjustments, and these are because the baby is learning to live on their own. They've been reliant on the umbilical cord and the placenta all this time, and they haven't had to mediate blood circulation or respiratory exchange by themselves. So you have the closure of the foramen ovale, right, as well as the ductus arteriosus, and the formation of those fetal remnants, the ligamentum arteriosum and the fossa ovalis. And this is all because you have blood now that can make it to the lungs. And so they don't have to bypass the pulmonary circuit any longer. And at this exact same time, because of the change in the position of the heart and of the lungs as they begin to inflate for the first time, you actually have a situation in which the two holes forming the foramen ovale just no longer line up with one another. And so blood can no longer pass through that opening. The transitional period is the first 6 to 8 hours, and the neonatal period is the first 4 weeks of life. Lots of adjustments being made here. You'll hear a lot about what's called meconium. It's the first stool that's produced by the baby. And it's typically very different from what you'll see for the rest of the baby's life. But this meconium is basically a tar-like substance that builds up within the large intestine as a result of drinking amniotic fluid instead of having actual food that they've digested. As far as lactation goes, this of course is mediated with hormones and their interaction with the mammary glands. We've talked about the fact that the mammary glands develop throughout pregnancy due to high levels of estrogen, and that this is going to help to couple the activity of progesterone developing all of the acini within those individual alveoli of the mammary glands. And of course, with milk production, milk is going to be a slightly different makeup to what you would see as far as cow's milk goes, especially in the earliest stages. And we refer to this early stage of milk as colostrum. It is very high in protein, less fat than what you're going to see in a lot of the milk from here on out, and it has a pretty high level of antibodies. And so colostrum is the most important milk that they get. It's a lot easier to digest. But of course, the mom stops making colostrum and transitions into typical milk, breast milk, over a period of about a week or so. And so then the milk will actually change in color and texture as you start to see more fat brought into the milk itself. The mediation here from hormones is of course going to rely on prolactin, and that's because prolactin itself is what's going to cause production of the milk here. Now, even though it's at high levels all throughout pregnancy, the high levels of progesterone and estrogen as steroid hormones prevent prolactin from causing milk production until the very end. So once you've actually delivered the baby and those hormones begin to drop in level, the progesterone and the estrogen, then prolactin can start to stimulate breast milk. And so essentially what happens is you'll see a minor amount of breast milk that might start to show up in the days leading up to delivery. And as soon as the baby is delivered, a mom can typically begin to make breast milk, small amounts, like maybe a half an ounce, maybe a tablespoon or a teaspoon. And that will start to increase pretty rapidly based on how much she actually breastfeeds. So kind of like labor and delivery, breastfeeding and milk production is a positive feedback mechanism. So as you have mechanical stimulation through suckling, or through a pump, right, which would be used, especially if the baby is in the PICU, that's going to cause oxytocin release, right, from the hypothalamus and the posterior pituitary, causing what's called the letdown reflex, and that's where milk ejection takes place. Now, as this happens, as you eject milk, that causes the hypothalamus to basically build up more ejection. And so this is going to just continue right here until the baby stops nursing, and then ejection will stop. Now, at the same time, that mechanical suckling stimulation will cause the baby to release factors associated with prolactin, and that's going to cause more milk production. So essentially, the more a woman nurses, the more milk she makes and the more frequently she can nurse. As soon as she starts to space out the time she spends nursing or drop nursing sessions, milk supply is going to start to wane a little bit. And so here I began to analyze a little bit of what we saw in that image, including the benefits of nursing. So one of the interesting things right over here, we mentioned the fact that nursing causes the uterus to contract and basically reduce in size. It's important here to note that nursing itself can suppress the release of gonadotropin-releasing hormone, and so it tends to delay ovulation, which is one reason people use it as a natural form of birth control, but it's not 100% effective. They also find that the milk that's being produced by moms actually has better absorption than what you would see in formula, either the liquid formula or the powdered formula. With the powdered formula and the liquid formula, they actually have a lot of really good nutrition in it, but the babies can't get to it quite as well. At the same time, babies tend to end up a little more constipated with it. That being said, formula is exceptional nowadays. There's a lot in it. It's really good. And so you should never ever shame a mom if she's unable to breastfeed, or even if she just doesn't want to, right? Because there's a lot of reasons for a lot of choices that people make. So of course the benefit to the mom though is that it's very relaxing. It causes oxytocin release, and that effect can be pretty soothing and promote bonding, and it burns up to 500 calories a day for the mom if she's nursing through the day. So it helps women lose weight pretty quickly. We're pretty lucky here in North Texas to have what's known as the Mother's Milk Bank, where moms can actually donate breast milk that they have pumped and then stored and then maybe didn't use for whatever reason. And it goes through a process where they actually goodness, now I've forgotten the term. They pasteurize it, essentially. It's a pre-flash pasteurized process to get rid of bacteria and things like that. But then they can give it to babies in the PICU or babies whose moms have passed away, things like that. And so it's pretty neat. This is something I actually got to take part of when we lost Joy. So as a result, Joy has a little leaf on the tree at the Mother Milk Bank as one of the babies that are responsible for supporting the lives of other babies through milk production. So anyway, so cool things there. Again, this is an incredible resource, and I advise you guys to look into it. But you may see this quite a bit when you're working in hospitals. And